Dear colleagues, thank you very much for coming, and thank you for being ready to speak on the drug registry problems and the problems of the human rights of people who use drugs and of their access to the services. First, we will start with logistic issues. We do have interpretation here available. So to hear interpretation, please press the globe sign down in the screen and choose Russian or English channel. So the webinar available, and if you will have any questions, suggestions, doubts, and want to share with us your thinking, you could share it in Russian or English. Surely it could be some Georgian and Ukrainian, but that will be harder to achieve. But we could. We are very good. So I'm Hanna Dovbach from Eurasian Harm Reduction Association, and I'm very happy that we are conducting this next meeting of our consultations. And first meeting was before we issued the policy brief around drug registry. And for us, this moving from the post-Soviet tradition of using the registry of people who use drugs as some repressive tool, or sharing this data from this registry to police, or doing something with this data which is absolutely against the European and global understanding of private data. That's for us always sound as a leftovers from the Soviet past. But we know that a lot of systems and a lot of services in several countries of Central Asia and Eastern Europe still working with this system and understand their values, and there are a lot of outcomes from the registry. We know exactly what is the number of patients. We could understand how to plan treatment and how to work for how doctors could plan their work, and medical centers how they could plan their work, and also we all understand that every system, every database have their pluses and minuses. And today we gathered this meeting to think together with the experts from Czechia, Estonia, and Lithuania as examples how they are dealing with the data of patients, how they are dealing with the all systems of this driving license connected with this data of patients, with the permissions for several list of jobs connected with this list of data. So we will start with the presentation in a minute. I will ask everybody who are not speaking now to mute yourself. The webinar we are recording it for purposes of people who could not join right now, but who will watch afterwards, and we could publish it on our webpage and share with everybody who were registered. So from this point, I'm wishing all of us, all of you, good professional learning of how the system of patient recording and planning is working, and I hope that this will be useful for all of you and for your practical work. And I'm giving the floor to Ala Yatsko, who is a leader of civil society advocacy in Moldova in the drug policy and human rights. Ala, please, why you initiated this work actually?
Спасибо большое, Аня. Спасибо большое
Thank you very much, Anya. Thank you very much for your response to our need, to our sort of requirement in terms of organizing this event. And thanks a lot to the expert Mr. Subata, Dr. Subata, Dr. Moravchik, Madam Katra, for this opportunity to learn from the experience that is very valuable for us, because our country is looking more and more towards your countries, Estonia, Lithuania, Czechia, and it's not just about European integration. We understand that Euro integration is important, but it's just a tool to improve the lives of people. And that's something that is on the agenda for us. Yes, everyone working here. I see here we have almost every person from Moldova who works in this sphere participating. Thank you for joining us. This topic is very important for us. Drug registry, it's important in the view of human rights, and we are not just speaking about big human rights, something declared officially, but it's about simple things like access to treatment, because we don't have OAT everywhere. We know that only 30% of the towns have this access. That's because the demand is very low, because other forms of treatment do not exist, and despite the fact that it was approved and we have protocols, we have lack of medical personnel willing and prepared to provide such treatment in the regions. So we are willing to learn from your experience. We are willing to revise the existing practices, and we have had discussions with doctors, with psychologists, with social assistants. But for that, it is very important for us to learn from your experience first. And thanks a lot for your readiness to help us. Also, I'd like to thank the representatives of the Ministry of Health who have also joined us today. Well, Godspeed.
Thank you, Alla. Thank you for making these questions more vivid. What we are talking about, and I wanted to say that I suggest this form. If you have some thinking or questions, write inside the presentation. Please write them in the chat, and then I will collect them and give to the speaker. And we were planning that we will have at least 2 hours. So we will have some time for us to discuss every examples. So we will have 15 minutes to present or something around this, and then us answering your questions. So please do not be shy and ask the questions. If you want to be anonymous, you could send them privately to me, and I will not say who was asking these questions, because I could understand that there could be a lot of layers of the problem, and maybe we don't understand some layers. And let's think about it, how to not to lose what we gain in existing systems, and in the same time to ensure that we are protecting people's rights. So without further ado, I'm giving floor to Ms. Katri Obel-Olo from Estonian Department of Drugs and Addictions, and she's head of narcotics department in Estonia. Katri Katri working for 20 years in monitoring of drug situation, and she knows how it worked before and how it's working now. So maybe that will be the key point for us to learn. And I could not name Estonia post-Soviet country. I'm sorry, because this movement was really very fast and very fascinating for all of us, how systems were rebuilt fast and very effective. Katri, floor is yours.
Thank you for the kind words. I will try now to share my... You see it? Okay, excellent. Indeed, I have been working more than 20 years even in this field, and I kind of feel like dinosaur already, but today I will give you a very short overview of our drug treatment register. Like Shanna already said, I was part of the previous registry also, what we call database, because it was without ID codes. But since 2020, we have personalized treatment registry, where we actually collect all the drug treatment entries in Estonia. Or at least we would like to collect. I will say a couple of seconds later why I call it the naive approach, because really we still cannot cover all the psychiatric healthcare providers who actually submit or like provide this drug treatment service. But yes, mostly we have them. It's an internet-based registry, and we created it, I have to say, like more than 2 years, because really it was a long process, lots of meetings, and now we can say that it's working. It's situated in our institute, National Institute for Health Development. And we have, I just put here the Estonian paragraphs. We have the special regulation for the registry, and also the registry is part of our national psychoactive substances act, because one part is there that all the psychiatric healthcare providers are legally obliged to submit actually the data. But it doesn't mean that it happens actually, but it's there. Before this drug treatment register, what abbreviation is NARIS, we had also NARIS, but it was, like I said, without identification codes. And what was the problem? That we created a very expensive code, unique, like this kind of a code center, what generated unique codes from based on the ID codes of patients. But still, the reality was that use codes to actually put together the end of the treatment and the beginning of treatment. So we couldn't form this kind of patient stories or narratives. We only had these episodes, what we entered there. And also we understood that also double counting was possible, and we couldn't link, of course, only for scientific purposes and with proper licenses, this register with other, like, for example, drug-related deaths registry or a TB registry. So we couldn't have the full picture of the situation. Why it's not moving? Okay, now it's moving. Then the question is, what kind of data is collected into this NARIS, what we have? Basically, it's socio-demographic background data, like date of birth, gender, education, nationality, occupation, and this kind of background data. Then it's, of course, drug use. We have the age at first drug use, main drug use, method of, and frequency of use. So we know if we are injecting or some other form of use. Then we have some questions, basic question about risk behavior, like needle syringe sharing, experience of overdose, etc. Then drug treatment, of course, is the most detailed information. It's diagnosis, it's type of treatment, medication start and end of date of treatment. And also extra for drug treatment, we have the comorbid diagnosis like HIV, Hep C, tuberculosis, and mental health disorders. So it's kind of an overview of the patient what we have. Then why we use this? I already a little bit explained that the previous approach wasn't so successful. But basically, ID goes, we treat them as a key. It's the key how we can create, like I mentioned, the stories, and it really enables us to link the patient data into a complete record. We have the full picture. That also we can, like I said, connect start and end transition between services, not only the patient story like horizontal, but we have also many services like rehabilitation, or we can see how the patient is moving between the different services that are provided in Estonia. Sorry. Then, of course, it ensures the continuity of data over time. We see that since 2020, how people enter and how they they have relapses, and on this is all recorded there. Then personal data is only for the registry, like I mentioned, and we like the last point, we link it with other registries only when we have the scientific ethic approval for that. It's not this kind of a whim, just think that we're gonna link something. It's only for scientific purposes. Why it's necessary? Why we need these narratives and stories? This is that to provide an overview of patients in drug treatment, and really to have this correct overview of this target group, what we really like to help. And it helps to assess also the quality of treatment, because when we see that people are just like going in and out, we see that something is actually wrong with the service. So this is really this kind of a quality stamp also, when we see that people go to treatment and they, of course, we know it's a difficult disease, but really some services we see the better quality standards than in others. Then we also, what was actually the main purpose why we created it, to actually understand what kind of how widely available should be treatment services, and what kind of support and help services are actually needed. This we do also based on the registry data. We see how many patients we have, what kind of services they use, and based on this background data, we also can assume what kind of services are needed. And of course, I'm a scientist myself. It's like the scientific research and purposes is also a great value of the registry. I just put here, we have had this now for 5 years, but I have to say that mostly we have incidents still we talk about, but I hope soon we can talk about prevalence also, because we have this, when the registry was created, then it started 2020 February, and by the law it was like from now on you should register all the patients, but it didn't say anything about persons who are already in treatment. Some of the treatment centers are excellent, and they have also entered the data of the previous patients there who were there before the 2020. But most cases choose very long-term stable patients who have been, for example, in methadone maintenance. Then it could be that they are not still in the registry, because the irony is choose patients who a little bit like go in and out. Sometimes they are most probably there, but the very long and stable patients, unfortunately, they haven't had a chance to re-enter the treatment, because they are there and they're really getting the treatment. But just to show you that with this 4 years, this is 4-year data, we have had almost like 1,060 for 649 unique patients there. And basically, the system has, I also looked at the other years, we have like approximately 400 first treatment episodes per year. Mostly they are men, but it's also because some of our treatment centers are like for men, for example, long-term rehabilitation. The more volume is for men than women. And that's why it could be like that also. Of course, there are other reasons also. Then we see what kind of, this is the 2024, that how many patients got the detoxification treatment and how many long-term rehabilitation and how many of them started the opioid substitution therapy that year. And we can have the patient age group, and based on the social demographic, we can do different analyses, and really they are done for the sake of the improving the services. So basically, we have lots of data we use 5 years now on. What we have learned, then I already mentioned that we would like to have that all the psychiatric service providers who deal with the drug treatment would be covered with the registry, but basically the most active partners are still those who are national, like part of the national addiction services, and basically they are because our institute has also the role of coordinating the drug treatment, and we have contractual relationship with most of our drug treatment services. So those our national addiction services are not a problem. The problems are private healthcare providers who actually also have the drug treatment in their services. And basically, I know that people go there to have sometimes the privacy, not to be registered somewhere, but by the law, they should have the obligation that they actually enter all the patients there, and it's really protected. It's our institute, and I know that 2 people in our institute are who can actually have the access to the treatment, and they are really by contractual relationship that they really honor the data protection. So, and we have these cases I mentioned in the previous slides also, that even if the court wants to have the information, then it's a lot of paperwork. It's not some phone call or something. It's lot of paperwork, and it's not always accepted the request. So it's not for the supply reduction purposes. It's for the healthcare purposes, and it's to improve the services. This is the main goal. Then smaller service providers also, they face this kind of administrative burden also, because I said it's an internet-based registry, and really you need to have all the equipment and also the time to enter the patients there. Then this is the beginning of the registry. The technical and legal challenges, really, like I mentioned, 2 years long meetings, memos, the parliament level. It was really a long journey what we took, but probably also the political situation in that time was the correct or suitable to say that we actually got it. I'm not sure if it would be so doable these days, but we haven't take advantage of it. So the data hasn't been there hasn't been a data leakage or something. Really, we protect the privacy of our patients. And also, this when you create this kind of treatment, then you really have to involve the service providers also, so they can feel that this is part of their needs also. And you need to motivate them. You need to have, like, for example, they would like to have is like 1-by-1 summary in the end of the year of their patient, and this kind of a tailor-made feedback to them. This is the candy what we offer to them, and really they need to be involved, and that they could feel that they have a right to say what kind of data we collect, and we really try to do that. And what is currently a problem is our prisons, because we have the 3 prisons in Estonia, and drug treatment is offered in prisons in Estonia also. And the prison personnel kind of thinks that even if it's written in the guidelines that if you go to prison, you have to stop finalize the treatment in freedom. And it's just written there that it was finalized because of imprisonment. But usually our treatment centers in freedom do that. But in freedom, in prison, they say that they don't start the treatment. They continue the treatment was already offered in freedom. So from the prisons, we have, like, I'm not kidding, the 3 or 4 cases per year only, but we should have like 400 or something cases per year. So we really have to work with prisons. Currently, we are starting to do that. And it's also the point that with this registry, you always have to be available, and it's not like it's internet based, but the person who is there should be very active, calling to the data providers and being a like very active person there. Otherwise, uh, the life of the registry would be quite quiet. And I think that I covered my main points. If you have questions, I'm more than willing to answer them. Thank you.
Thank you, Katri. I have immediately several questions just to clarify. You said that you switch from the coded or individual codes database for prevention, for harm reduction. You still have this confidential, not individual patients, or not patients, but clients of the harm reduction, or they are included in this database? Because we usually use this codes for harm reduction to make it completely anonymous, and nobody could recognize this first name of mother, second name of father, and all of these codes.
Yes, harm reduction is totally different. We have this anonymous and it stays like that, and we have the same code system there. But for treatment, as treatment has always been actually personalized in Estonia, then yeah, for treatment we have registry, but it used to be that based on this identification code, they made some extra code, but it was really expensive system, and Minister of Social Affairs was quite angry.
And one more question: why people don't afraid of the system? Because as you describe it, it's the best option of the drug registry, narco-uchet, and the only difference that you are not providing this data for police, for courts, or for somebody. You are not sharing this data, and I guess you are not using this data to issue spravki or this information that to people who are not in the database. How
No.
you are dealing with this license, the driving license certificates that person is not in the drug registry, or you don't have this system of checking if person have addiction, non-having addiction,
No.
have psychiatry challenges, or non-having psychiatry challenges?
We don't have this personal checking system at all. If we talk about driving license, then only thing you need is a family doctor checkup. And of course, this could be the issue when you openly discuss this with your family doctor, but it's really up to the family doctor to decide. And for example, also with methadone treatment, people who have licenses and ongoing methadone treatment is not a rare sight in Estonia. So really.
Thank you. That's and if how often you are checking the database? Because I know that in some of the countries there is problem with the мертвые души, or how to say, dead souls. Like people could be in the registry for 10 years and nobody will take it off, because even a person is already not a man alive, or maybe this person is not addicted anymore.
Yes, in that sense, if somebody started the treatment and ended it, it's just a historical episode there. We don't remove this episode from the registry. But if we haven't seen the person like in the next coming 5, or we understand that it's not the active case, because really we have the entering data and we have the finalization. And if there are no other appearances, then we understand that it was an episode. But we don't remove use because there is no point. It's the treatment registry, and we use it for treatment purposes. It's not based on some no, like I said, that we don't give any licenses, or it's not a bad thing to be in. We don't remove patients from there because there is no point. It's for the treatment purpose.
Okay. Alla?
У меня такой вопрос, связанный со спросом к лечению.
I have
Отметили
a
ли
question
вы,
regarding the
несколько
demand of
момент,
treatment.
когда
Have you noted,
изменилась
Kadri,
форма учета
at the time when you
стрелкой
changed
вверх
the
учета?
tool, the
Регистр.
Nairis,
Отметили ли
have
вы
you noted, did
рост
you note
спроса на
the
лечение? Потому что
increased demand for
мы
treatment
знаем,
after
что
that?
наркологический учет
Because we
является
know that
барьером
this
для
drug
врачей.
registry is
Люди не
usually
обращаются за
a
лечением, потому
barrier
что
for people
боятся этого
wishing to
учета.
access treatment.
В
People
случае
don't come
учета
for treatment because
они
they
не
are
смогут
afraid of being
реализовать
registered. If they
свои
are
какие-то
registered, they
права, например,
cannot
тоже право на водитель
get the
автомобиля,
driver's
может
license,
быть,
for
на
example,
устройство на
or
работу,
get employed.
права, связанные с интимной
Different
жизнью, там,
things,
дискриминацией.
something related to the intimate
Было ли
life, discrimination, and so on.
ощутимым вот тот момент,
Was
когда
there
изменили
a
систему учета
notable
с точки зрения спроса
increase
на лечение? То есть
in
больше людей
demand for
начали
treatment?
запрашивать
So
медикаменты
whether
за
more people
зависимости?
came to treat their addiction?
If I understood the question correctly, I think I did. No, we haven't actually, compared to the previous system, seen that people like avoid the treatment, or actually the scales are pretty comparable. And we haven't had also like the stories that somebody had like refused to go to the treatment because of that. Because really, I have to say, we honor the data protection, and that's why in the first slide we had also, I can go back. We did this kind of one pager to the patients also. It's in Russian also, that why this database is created, and there is like very, very easily explained why we need this ID code. That it's the key, and we need this key to improve your life.
Thank you. We have question from Pulod, like that there is the difference that all narcologists, even having the old narco drug registry, and what you are describing, all people who are dealing with the system, they're saying also about the protected data. So we need to find out what is the difference between what you have and what the old system have. And he have a question: what does it mean the treatment is finished? If it's detox or rehabilitation or both of it or something else?
It's just kind of this kind of technical term, that it's the entering to the treatment, and then if the episode is, for example, for maintenance, it could stay open for years and years, and it's open. But when we talk about detoxification cases, then it's like mostly 4 weeks. People go there, and after like 4 weeks, this episode is closed because it's only for 4. But of course, they can go aftercare or some other treatment services after that. That we also see. But this is this kind of a technical term, that all the episodes have the beginning and the end. The end could last 10 years also, or forever. Talk about substitutions.
Okay. Thank you, Katri. If there will be more questions, I will be happy to ask, and I guess there will be more discussion. And we are now switching to neighboring to Estonia, Lithuania, and I will give floor to Emily Subata, advisor to director of Republican Center for Addiction Disorders in Lithuania. Emily's one of the founder of our network, actually, 25 years ago, and one of the key person who know the old Soviet narcology system, and who put all the life and professional abilities to switch from the old system to the new system. And how does it work and how it's happened? Emily's floor is yours. I could not hear you.
And now?
О, отлично.
Okay.
Мгм.
Okay. Where is my presentation? I have lost it.
Now you need to share it again.
Okay.
Yes,
Okay.
and now this magic button to have a full screen. Yeah, marvelous.
Is it okay now?
Absolutely.
Yeah. Thank you, Kana, very much. It's a pleasure to be here, and it's a pleasure also to see some familiar faces. So I will try to provide some information about narcological registry, its transformation in Lithuania. But I also wanted to connect it with the system of service delivery, with the system of treatment of addictive disorders in Lithuania, and how stigma is playing very important negative role, and also narcological registry. So stigma impedes treatment delivery, and that means basically that health services see more complicated patients. And this is a citation from Nora Volkov, whom everybody knows. She works in NIDA, United States. And stigma also makes more difficult to fund health services to addicted persons. So particularly it was very seen in Lithuania, where National Health Insurance Fund was not willing to fund addiction treatment services. But in spite of that, we had quite a good dynamics for the last 15 years. The services increased about 6 times, both for illegal drug users and also for alcohol users. And I think this is a good indicator. And that happened because there was increased access to services. The services were better managed. Also, there were some efforts to reduce stigma, to describe addiction as a disease for public opinion. Also, it was improved quality and continuation of services and increased funding for the services. And there were increased referrals from the child protection service, the probation service, and municipal child welfare commissions. And last but not least was the efforts of the Ministry of Health to change the legal acts which determined how decisions are made on issuing driving licenses, also being employed in some professions like lawyers and prosecutors and judges and other areas where rights are not allowed for our patients, not for all patients. So we were lucky that since 2018, in the Ministry of Health, we had a very motivated and very energetic team who worked in the mental health department, and they declared that they are creating the new generation of mental health services. And indeed, in the past 5 or 6 years, they did a lot. So this is the diagram which shows the system of addiction treatment services in Lithuania. So on the top, you see the population, and population can apply directly to GP team, general practitioners or family doctors team on the left, or mental health team on the right. So both general practitioners and psychiatrists in mental health teams operate on the primary healthcare level. That means that they have the fixed populations, they provide services. General practitioners team and mental health team can refer patients if needed to specialized care, which is addiction psychiatry, and which are inpatient, outpatient services, or medical rehabilitation. And of course, after treatment in the secondary specialized level, patients should return back to mental health team mostly, and continue treatment on the outpatient basis at the mental health team. So GP, they do not do a lot with addictions. They do audits, early alcohol screening and interventions, but the main task is the main job is done by mental health teams. Also, there are preclinical services which are anonymous and free. These are harm reduction services, which are targeted mostly on injecting drug users, and also public health bureaus. About maybe 5 years, we have addiction counselors working in public health bureaus, and they provide individual counseling for patients who want services of this lower level. So mental health teams are crucial. There are 116 mental health care teams in Lithuania, and they are spread all across Lithuania. So it is basically a municipal treatment facility, but they can be municipal or private also, and they get funding from the National Health Insurance Fund. So mental health team usually consists of psychiatrist, child psychiatrist, mental health nurse, medical psychologist, social workers, and there could be other specialists. Mental health teams also provides innovative approaches like community treatment teams and case management, but it's more in the mental health, not in addiction treatment. As you see, there is no narcologist there. So psychiatrist is the doctor who treats addictions also. So very important is that mental health teams receive additional funding for their work with addicted patients. So, and the continuous treatment is encouraged, and only the round of 6 consultations is extra funded by National Health Insurance Fund. So if a patient gets only 5 consultations per year, he is not rewarded financially. But 6 consultation is a service, and it is additionally paid for the mental health team. One consultation must be by a psychiatrist, and 5 other consultations could be by social worker, nurse, medical psychologist, or other specialists. So majority of patients receive can receive one continuous treatment, and more complex patients can receive 2 or 3 treatments per year. And buprenorphine naloxone is provided on the primary healthcare level and is funded extra with 18 consultations by a psychiatrist. So what is the role of Republican Center of Addictive Disorders, which is national center under the Ministry of Health? So its objective is to support mental health care specialists. So it is done by consultations of specialists, trainings, and developing of clinical guidelines. We understand very much that many psychiatrists they do not know how to work with addiction patients. Sometimes they have no patience. Sometimes they see these kind of patients as less important than others. So I think this is a very important area of work for our specialists to support mental health teams. Regarding the registry, EU has passed very strict legal laws in 2016 and on personal data regulation, and each country in EU has to develop national laws which protect personal information, and patients' information is considered as the most vulnerable and most important to protect. So, of course, there is no possibility to share freely this information with other agencies. And substantial financial fines are can be administered for the breach of personal data. And usually each legal entity, not only the treatment facilities, but any legal entity which operates with personal data has to develop national its local personal protection policy. So narcological registry, we are very familiar what it was in Soviet style, and it is of course major stigma, and it prevents service normalization in countries. So its basic goals were to provide statistics and trends of drug use, and another goal is to ensure safety of the society, public safety. But narcological registry does not fulfill any of these goals. So how personal data is managed in Lithuania? There are 2 digital databases. One is called eHealth, and where all diagnoses and consultations and referrals are put there. And the other, Svedra, is for financial reimbursement. We don't have yet a drug treatment registry as in Estonia, but we'll have maybe next month or in December. So next year, I might maybe tell you if it's working well or not working. It would be quite similar to Estonian drug registry with personal codes, but maybe the difference is that drug treatment data, the system is included in e-health, so that practitioners, when they see patient and they put information about the patient, they will also will put info about the data which is required by drug registry. We understand that this is treatment demand indicator and this is a requirement from EU, and this will be used solely for statistical purposes. And another institution, Drug, Tobacco and Alcohol Control Department, will use the personalized data for analysis and reporting. So this is for statistics. And regarding the Ministry of Health limitations due to health status, there are, of course, limitations stated in the legal acts, and they also determine not only addictions and mental health cases, but also all different systems like whatever health problems can be. So, of course, there are limitations on driving, on possessing guns, on being employed in certain professions. But it's not fixed, so it allows a lot of room for clinical decisions. So mental health and behavioral disorders caused by psychoactive substances in remission stage are determined individually, considering the duration and stability of the remission. And these are citations from the legal acts of the Ministry of Health. And the driver's licenses are not issued or renewed for individuals who regularly use psychotropic substances, and of course, when it may impact driving of the vehicle. So a lot of room is made for clinical decisions of doctors. So at our center, on the specialized level, we, of course, provide specialized treatment services. They are in 5 biggest cities and cover the whole territory of Lithuania. And there are different services, like outpatient services, including opioid agonist maintenance treatment, other outpatient services, child psychiatry services, consultations to family members, according to the methodology of Kraft, day psychiatric unit, day child psychiatric units, and all services are entered at local database at the institution, specifically for issuing certificates. The same is with inpatient services, including detox, Minnesota 28 days inpatient program, motivational rehabilitation, 15 days programs, child psychosocial rehabilitation unit, and again, all services and recipients, patients' data are entered at the local database. So if the individual asks, our center provides health certificates to individuals about the treatment services. Certificates are issued if an individual received services. If certificates are issued online, if an individual did not receive services at our center during the last 5 years. And if an individual received a service, a doctor assess the patient status and makes an individual decisions, and he gives this certificate to the patient, and the patient can carry it to other institutions. So basically, most of the individuals order now online through the institution's webpage. So they fill the order form, pay for the service online, receive an email about the completion of the service, and then download the certificate from the e-health portal. And the basic information they must fill in is the first name and the last name, email, personal identification number, and that's it. So data from our center goes to mental health team, and there they can add information about other mental health issues, and we can provide certificates for driving, for having a gun, or whatever is needed. So in a way, in Lithuania, it's decentralized. As I showed you, 116 centers at the primary healthcare level, they can decide it clinically on the individual basis. So if there are questions, I will be glad to answer. Thank you.
Thank you, Emily. Thank you very much for detailed explanation. Again, I see that the difference between system which you have and the system which we're trying to change as a drug registry existing in Central Asia or Moldova is not very different. And I'm trying to catch what is the difference. A part of the giving the list of people who are using drugs to police for their investigations or for their indicators. Again, I don't know if it's still happening in some of the cases in the countries. Dear colleagues from Moldova, from Central Asia, maybe you will ask the clarifying questions. If it's easier, please ask in Russian, and Emily could answer and explain in the details. Please.
Я спрашиваю, потому что знаю от своих коллег.
Представьтесь, пожалуйста. Could you introduce yourself, пожалуйста, Женя?
Какие сестры?
That was not to us. Okay. Please, could you ask your questions and clarifying questions, but introduce yourself from the very beginning. Colleagues, do we have any?
Здравствуйте, если можно.
Hello,
Я Сильвия
I would like to
Герасим,
ask a question. My name is Sylvia Gerasim. I'm the chief consultant at the Ministry of Health of Moldova, and I have a number of questions. First of all, I wanted to say that thanks to some changes to legislation recently, Moldova is moving closer to the personal data protection system that is used in Lithuania and Estonia and Lithuania. So, and still I have some questions, like in the recent 10 years, we have had a reform, a mental health system reform, and we created mental health centers distributed in the country, and these centers are a component of primary care, and the Ministry of Health is actually planning to merge the mental health services and addiction services, and the addiction specialists who are now working in district hospitals or district clinics will actually enter the district mental health teams or psychiatric teams. So, of course, that might require additional training for addiction specialists and mental health specialists, but my question is, how many psychiatrists we need to have, or like one psychiatrist per how many people would be efficient? Because, of course, in this case, 1+1 does not equal like 2, because it would not be enough to have one psychiatrist per, say, 40,000 people. And again, psychiatrists have to deal with mental health problems as well. And we do know that most of our patients usually have double diagnosis, and we cannot differentiate between these diagnoses in many cases. So if you have one mental health team, how many people this one single team can serve? This is my first question. And my second question, which refers to another part of your presentation, is what kind of data do you enter in eHealth and in Swidra? You mentioned that you are entering patient data. What kind of data? Personal data or health data or any other data? And one more question is as follows. You mentioned that in case the patient does not receive services for 5 years, then he or she get a certificate without any consultation from a specialist, even an online consultation. So it's sort of tricky because patients who know about that and who used to be drug users like 5 or 7 years ago might actually purposefully refrain from consultations in order to get a certificate later on. So how can you avoid this problem?
And now probably the final question. If the patient was on the inpatient treatment, you say that the information about it in our case is sent to the in our case mental health psychiatric center. Do we need to get the consent from the patient for that? Because according to our law, there is a regulation stating that without the consent from the patient, you cannot share the data of his having received treatment at a psychiatric clinic or addiction clinic. So we need the permission from the person. And we had some debates about that, but the provision of data to other health workers outside of mental health area or between inpatient and outpatient services. That's a question. Thank you. Thank you for your questions. I don't know whether I have been able to remember them all, but the first one was about the calculation of how many health workers you need per population. So initially we had 40,000 people per one psychiatrist. Now I believe, if I'm not mistaken, it was lower. Now it's about 15,000 for adult psychiatrists and about 8,000 for children's psychiatrists. And 15,000, if I remember that correctly, it's for all other specialists. That's nurse, mental health nurse, social worker, medical psychologist. These are the norms right now, 15,000 per one. So basically, when we had the initial drafts of laws and regulations, initially we had to have a narcologist in the team, but it just happens that in Lithuania everyone wanted to be a psychiatrist and few people wanted to become narcologists. And also, as you have noted correctly, there are many mixed diagnoses, and all those addiction treatment psychiatrists were remodeled, so to say, and they became psychiatrists. Just that. And in the job description, it says that all the psychiatrists need to be able to do substitution maintenance therapy and detoxification. So everything is there in the standards for psychiatrists, and we don't have narrow addiction treatment psychiatrists like for 15 or 16 years. I know that in Latvia they kept narcologists in the system for a long time. They still have them. They had a special internship for narcologists, but I know that this is the first year when young doctor students did not want to become narcologists, so they have none. They train none. So basically, if we create special separate courses to teach narcologists, giving them the necessary knowledge of psychiatry, I think it would have been a good way to resolve the problem. That's my personal opinion. Yes, I totally agree with that, because moreover, our medical university, they don't have special advanced training on psychiatry and narcology, just 4 years and of training, and they make psychiatrists of residency treatment, the therapy, and they are capable of working with addictions as well. But I just wanted to clarify, what do you include in eHealth database? What data you input? Well, eHealth database is a system that mostly is used for doctors to share diagnosis of a patient when they interact with other doctors, and vaccinations, e-recipes, e-prescriptions, and everything that is standard for e-health, everything that is written in the paper-based health records, all the same data are found in eHealth now. And this system, well, it is accessible to other doctors and to nurses, but only to doctors and nurses. Now, with regard to the mental health and addictions data, they can be more sensitive than other medical data. This is recognized in Lithuania in principle, and for the last about 3 years, a separate subsector on mental health has been created, and it takes time to fully establish it, but I believe this is necessary to ensure that not all health workers could access that information. Only family doctors who need that, or other psychiatrists providing the treatment. So we need to reduce that access, limit it. But so far, the system is not operating yet. The Ministry of Health says that this year it might become operational, but right now the patient sees all the documents that doctors write about them. They can use their account to access the data, and that's the e-health system. Now, talking about Svidra, well, their forums are completed with information about provision of services, outpatient or inpatient or rehabilitation services, and those forms are used by the funding organizations to pay for the services. So this way the healthcare facilities receive the funding per patient. They are very short forms, where you just indicate information about the services. I just would like to clarify, if I may, right now, doctors of other specialties, they can see information about a patient who has mental health problems or narcological problems, I mean addictions. And yes, if I may, I'd like to clarify that the Ministry of Health did not strictly require psychiatrists to provide data about their patients about this sensitivity. We entered the data actually about addictions because we wanted, like when the patient comes home, then the mental health center could see how it was, what has been done, and so on. But when this subsystem is created, then yeah, all the information should be in there. Yes, and to enter this data, you need a special consent from the patient, or it's done automatically for everyone coming for the services. Consent from the patient is not required for each particular case, but there is a function for the patient to ask, to require to remove their information from eHealth. I have not encountered such cases, but I know that in theory, patients can request the removal of their information. And now, with regard to 5 years, do your patients use this regulation to avoid, to get access to professions or to driver's license and so on? You see, the decision is made by the mental health center where the patient is registered. That's the responsibility of the center to get the real information, to examine the patient, and this patient is observed by this center longer than by us, the secondary treatment institution. We are responsible only for our information, whether the person got any treatment in 5 years, whether they have not come to us in 5 years, we tell. So if for 5 years maybe they left somewhere or the patient was absent. That's again a different thing. So this information, I think, we don't always provide this information because they don't always ask for it. But if the patient requests information from us, we provide it. Without us, there are other sources, psychiatry clinics, toxicological departments of hospitals, resuscitation units. Like, we cannot provide all reliable verifications about a person's not having addiction. There are private clinics where they get treatment. So this is done at the level of primary care. That's where they deal with it. That's a family doctor, that's a psychiatrist, that's who do this. Thank you very much.
Thank you, Emily. Alla wanted to ask something. Alla?
I have the following question that came as a sort of thought during Emily's presentation. We have the narcocho drug accounting, so to say, and drug registry. Those are different things because the register is a tool that can be based on various rules, anonymity, coding, and so on. But this narcocho, this accounting of drug users, that works in Moldova just like it used to work in the Soviet Union. It envisages that a person can get pharmaceutical therapy with opioids if the person is registered. So the person came to the doctor, the problem is there, it was recognized, so the person is ill and they have access to treatment. Now, without this registration form, the person cannot access treatment. So if the person is registered, then they have this addiction that involves treatment with opioids. So most probably they will be registered for 3 years. Well, if they keep coming for these 3 years, showing up, otherwise it can be 5 or 7 years or more. And despite the fact that this is a monitoring by the treating doctor, on the other hand, there is no active interaction between them, because very often patients don't even know that if they don't come to the doctor, even while they don't use the drugs, it still creates a problem for them. They don't know that they need to come, and then they can be deregistered and get to enjoy all their rights which they lose when get registered.
Эмилис, я знаю, что у вас долгая институциональная опыт
I
и
know
память.
that you have a very long institutional experience and institutional memory. So when the change happened in Lithuania, because you know we have a special regulation on so-called narcological registry, and the legislation also requires this registration, and all these pieces of legislation need to be reviewed and revised now. So could you please recall how it started? Or maybe Mr. Bravchik would remember that. How did you manage to have the legislation changed? Thank you. Well, yes, indeed. Our legislation also envisaged so-called narcological registration, and the facilities had to register. But in reality, the mental health centers at the primary care level, after they were established, they never actually kept the records or registered the patients. So the medical facilities never did that. that. And no sanctions were imposed ever because everyone realized that that was something unnecessary, just a formality, taking your time and not giving you any benefits. So several years ago, then the health law changed. The new law actually no longer had that requirement, and so we do not keep the records anymore. And when you need to provide substitutional therapy and you are a doctor, you don't need the patient to be registered. You need just to review his or her status, history, and no registration as such would be necessary. So indeed, you need to revise the legislation. I do understand that such registration or registry might be necessary for statistics, but not for treatment, because in healthcare, it would be even harmful to have such a registry, preventing people from seeking treatment. Thank you so much. So do you understand it correctly that the mental health law also includes, in your country, also includes addictions, so without any separate addictions law? We used to have an addictions law in 1997, but now, yes, it's part of the mental health law. Thank you.
Very vivid discussion and a lot of details, and we also have comments in the chat. And I wanted maybe Katri and Emilis could see the chat's questions, but we have one more speaker, Viktor Mravchik from Czechia, and Czechia never had the drug registry, but Viktor, again, we have people who are working in the area for 20 plus years and registering patients. So let's hear how Czechia is doing with the registration and all the functions which drug registry is paying. And Viktor Moravchik is PhD and a social professor, vice chairman of the board of the Society for Addiction Diseases of the Czech Medical Association, scientific advisor to the National Drug Coordinator, and head of Czech National Monitoring Center for Drugs and Addictions for 20 plus years again. Victor, please, the floor is yours.
Спасибо. Вы слышите меня?
Thank you. Can you hear me?
Yes, we could hear you. Yeah, very well.
I will be speaking English. Yes, indeed. In the Czech Republic, we never had any registration. We had different systems for recording, but we never had any register for social control purposes. So can you see my presentation, my slides?
That's perfectly well, yeah.
Thank you. Also, maybe it's good to say that I was working as a head of the National Monitoring Center for Drugs and Addiction for almost 20 years until 2021, and I, established the system of drug monitoring in Czech Republic, including the register of drug treatment. Yes, so I have some experience in this field. It was already said by Katri and others that we use data from treatment, data on patients treated for the substance use disorder for statistical purposes as a part of the complex monitoring system. Yeah? I'm not going into details, but of course, to describe the situation in substance use in a country, we need different indicators, and the data from treatment is one of them. If you look at the EUDA, this European Union Drugs Agency, former EMCDDA, and the system of data collection is very complex. Yeah, we can say that there is a basis of routine monitoring of different indicators from population, from treatment on the clients of services, on drug-related deaths, infectious diseases, and so on. And on the top of that, and it's more and more important, I would say nowadays, there are the different data collection systems and registers, functions to track the emerging trends, new trends, including this early warning system. But what we can say is that the treatment demand data, or how we say that in EU treatment demand indicator, is part of the basic set of the key indicators we say on the drug situation in a country. So it's to say that it's important. It's important to have these information systems and to collect the data on clients in substance use disorder treatment services. Yeah? Well, Katri already said, the primary objective of the treatment demand indicator or registries in EU is to provide data on the number and characteristics of people starting or undergoing addiction treatment. We discussed already the difference between the first treatment demands and all treatment demands and so on and so on. But basically on the people who are in treatment in the country, in the respective country. Of course, there are secondary objectives. We discussed some of them to identify patterns of the utilization of services. So which kind of services are used by the clients? Treatment coverage, it's very important to assess how many of the whole population of people who use drugs is covered by this or that treatment, and so on and so on. But it's important to say that the purpose of the system is to monitor and to research, not to control, not to have the social control over the people. Of course, and Katri and others already mentioned that there are issues of identification of individual clients in order to track them through the registries and so on and so on. And very important issue of personal data protection. And so there are issues on the how to register people and so on, but they are linked rather to confidentiality and privacy of people, not to, social control over them. In my professional career, I was working in many post-Soviet countries, and there is always a problem of narcological registration, because the primary objective of the registration, this narcological uchot, narkologicheski uchot, is social control over people who use psychoactive substances. We know that there is this, usually there is this preventive and dispensary registration, the follow-up period differs according to preventive or dispensary. It's ranging from 1 to 3 years. Also here it depends on the country and so on and so on. But what is common is limitations of rights of people and discrimination of people who are registered with regard to driver's license, jobs, loss of custody of children, education. Even in some countries, there is a control of the presence in the registry when person wants to get married and so on and so on. So, and it's common for all the countries that the narcological registration, this narkologicheski uchot, represents one of the most important barriers for seeking care. It increases stigma. There is a shame and fear of registration for obvious reasons. We already discussed and presented. Increases distrust in the system, so people distrust the professionals, and also increases the risk behavior. It's well described in several countries, of course. So in Czech Republic, we also register clients and patients in addiction treatment. We use various data sources. We don't have only one system of registration. We have the most important registers we have for description of the situation is inpatient treatment registry. So we have the register on all hospitalizations in Czech Republic, including hospitalizations for the substance use disorder. And then we have National Register of Public Health Services. It's the best translation I can have. This is the system, a national registry based on the reports from the health insurance companies who pay public treatment in Czech Republic. And we have 7 companies, health insurance companies in Czech Republic, and all of them are contributing to this registry, and the data are compiled in one registry on the all treatment episodes, outpatient and inpatient, covered by public money, by this public system of health insurance. Then we have monitoring of subsidized addiction services. We have system of state subsidies to some of the addiction or drug services, especially harm reduction services, those who are not covered by this health insurance system. And those are also obliged to report the data on clients and so on. And for example, on harm reduction services, we collect the data from this system. And on top of that, we have special National Registry of Substance Use Treatment, which is based on this treatment demand indicator of EUDA standard. It's running now more than 10 years. It's used solely for statistical purposes, for research and monitoring. We can combine the data from this register with other registries. It's important to say that all of those registries have the status of national health registers. So it means that there is no need for consent of the patient to be reported. It's simply obligatory for any treatment entity to report to the register. There is only function of this National Registry of Substance Use Treatment, only control function, and this is a check of personal identification number when person starts opioid substitution treatment, in order to check whether he or she does or doesn't get the substitution in other treatment center. And again, Emily's mentioned and Katri mentioned that confidentiality of the data is a must. So what is reported to the register stays in the register. Of course, there are social control functions of a healthcare system in general, or addiction care system in Czechia. So it's also used in order to control over the individuals with the specific socially unacceptable behavior, I would say, yeah? For example, first, it's compulsory addiction treatment. You know that, you have that also in your countries. In Czech Republic, this compulsory treatment can be ordered only by court. It's very controversial in addiction care in Czech Republic. There is big discussion on that because it's found to be counterproductive in many cases. If there is no motivation of clients, it simply doesn't work. We know that, and now the system is under reform, and so it will change. But we still have it, even if it's not used that much as in past, I would say. Then the main social control functions in Czech Republic in healthcare is delegated to general practitioners. Emily's named that family physicians. Yeah, those general practitioners are the primary care specialists who are taking care of the healthcare of people. We have the system in Czech Republic when every person, adult person, has to be registered in one general practitioner. So it's clear that who is my general practitioner, even if now there is estimation that 10% of Czech population is not registered in general practice. But anyway, yeah, so this is the general practitioner having this social function, gives statements for driver's license, for weapons license. So if the person wants to get the license, goes to the general practitioner, asks for the special, the bumashka, yes, special, the form, and it gets it and present it in the authority issuing the licenses. There is obligatory reporting to the registry of drivers or weapons license set by the law when the person loses ability. And of course, the substance use disorders are among the conditions, as already Emily's also showed. We have it similar. When person is addicted, then it means the disqualification with regard to the driver's license and weapons license. It's obligatory for every physician, not only general practitioner or addiction treatment specialist, every physician to report to the authority, to the license registry, if he or she finds the person not able anymore. And again, here it's controversial with regard to addiction treatment because, and it gets even stronger now because since the beginning of this year, the law changed in order that information about driver's license and weapons license is obligatory part of the health care documentation on the patient. So before, general practitioner or any other physician could say, well, I am not informed if the person is holder of the license or not. Now it's obligatory to collect this information, and it gets difficult to somehow bypass this obligation for the physicians. But in addiction care, it's largely disregarded because simply it's nonsense. It's counterproductive. If person is seeking the treatment, is asking for the help, and to punish he or she, him or with this reporting to the authorities. So it's very controversial. It's still under discussion in Czech Republic, but it's not linked to the register, to the national register of drug treatment. So conclusions or preliminary conclusions here, my conclusions are the treatment and demand registration should be used primarily for statistical monitoring research purposes. Of course, there are social control functions also in the healthcare, but social control of the treatment demand registration, UCHOT, should be avoided since it increases stigma and discrimination of people seeking help. And of course, social control of addiction treatment should be carefully balanced with human rights and public health objectives. Yeah, so very probably we will not get rid of some of the control functions of the addiction care, but it should be very carefully balanced with human rights and public health objectives. Here I have some references to information I have stated in my presentation, and thank you for your attention.
Thank you, Victor. And actually, references will be very, very useful because if Moldova or other countries will prepare the justification why the system should be revisited, then there should be some links on the justification and scientific evidence. And I will share, if you are giving permission as a speakers, you, Katri and Emilis, I will be happy to share your presentations with the participants for their reference, if it's okay with you. Actually, we still have 20 minutes if there are any other additional questions and clarifications, because this balance is very tricky. You are right, Victor. So there's like getting the personal data, which all systems are getting, and not letting it out for some people who don't need to see them. We have questions from one of the participants here. That's about again 5 years of the breakout in the recording. That was the question about the personal decision of the doctor who have. Maybe Lilia Fedorovna, maybe you want to ask it personally, it will be easier. Pani Lilia? Oh.
Ага, добрый день, здравствуйте.
Yes, good afternoon.
Меня этот момент очень интересует.
This thing is very important for me. So our patient, we have a patient for 5 years. We've not seen them. They are traveling. They are taking drugs. We know it's chronic, and they are not always registered in our observation system. But 5 years they are absent, and then this gap allows them to easily get a driver's license. So what interests me more is what's the role of the doctor in this decision making? Do they make this decision personally? Because we have the practice that 3 years after each therapy, inpatient or maintenance therapy, the patient needs to have a meeting with a doctor for the doctor to observe their conditions, to be able to make decisions about making some treatment solutions. So if the patient has not been taking drugs for 3 years, and the doctor can check that, then the commission of doctors make a decision about the registration of the person, allowing them to get the driver's license. Again, if the patient on OAT, but we anyway include them in the register, because this word учет, registration, it sounds bad, but we understand now after we hearing from the speakers that all the personal data and the treatment data is registered. Different things in different countries, but you collect all the data. That's registry. That's it. Yeah, right. So far we call it учет. Maybe just different word. Thank you.
Who want to answer? I see the key answer, Pani Lilia, that the level who have the data, who have access to the data. That's for me the key difference. What Emilis and Katri and Victor are describing, yes, every doctor have the учет and registry, a database of patients. But the problem is who have access, and do we issue the driving license documents just because person is not in the registry, or we see the patient. That's the difference. If the narcology doctor or psychiatrist or primary health, as in Estonia, to have the driving license and to medical certificate for driving license for any profession, see the patient, then the drug registry is not used for that. Then it will not make a lot of human rights violations. Because if it's just you've been on a treatment for OAT once, you already been there, and it means that no driving licenses for ages, because nobody reviewing it or somehow. that's the challenge, and for me, we need to clarify how does it work, because I know how drug registry worked in Ukraine for ages, and nobody reviewed the data of it, and so people that already still was in the registry and still couldn't get the driving license. Sorry for my irony. Victor.
I'm not sure I understood. Every aspect of the question, but what is also important, and you mentioned that, Jana, that who has the access to the registry? For me, very important question is when the registry is consulted, in which moment, yeah? Because in Czech Republic, we also have the control over the people who are asking for the driver's license or the weapons license. Yeah, they go to general practitioner for the check. So they have to be seen, they have to be checked. If there is doubt, they are sent to the specialist. But the registry is not consulted. It's irrelevant whether the patient was or was not treated in drug treatment. This fact per se does not disqualify the person from having the license or not. Another point is when the person loses the license or for the driving or for the weapon. Due to the loss of ability, then we have the period of follow-up of the patient. So the patient has has the right to get the license back after I believe by heart it's 1 year now. After 1 year, after the medical examination again, yeah, of the specialist as well, if general practitioner wants to consult the specialist. But again, register has nothing to do with this system. Yeah. So and in this way, we simply don't misuse, sorry for this word, the registration of the patients for these social control purposes, and then we don't have a problem with the distrust of the patients to go to treatment and to be registered, because simply it doesn't have the how to say that link, yeah, link with their rights. Yeah, so, thank you.
Thank you. Emilis?
На вопрос Лилии.
Answering Lilia's question, what can I say? Well, our institute does not take part in that control. We do not perform that function. And this patient, on the one hand, we don't see them for 5 years, and we don't have the grounds not to give them the certificate about the fact that they had not received treatment for us. But yes, if they have not come to us for 5 years. So we give it, the certificate.
Well, we never know. Maybe the individual was treated by private settings or maybe abroad. So this is something addressed by the mental health center at the primary care level, and they see the percentages and they can actually ask for additional information from our center, from a psychiatric clinic, from a family doctor, from the previous mental health center of the individual. So they are in a better position to make these decisions. Of course, they might make mistakes, but we need to realize that 100% control or monitoring is never possible. Neither your systems or our would ensure 100% control, because some people, they have the tendency to address this or that clinic, or maybe they undergo some administered treatment. So we can never ensure 100% monitoring or control.
Alla, please.
Well, I just recalled the situation about the certificates of criminal records. They are also usually issued upon request and are issued in case there are no data or data are missing. So if there are no data available, nobody is ever gonna look for some extra data. So the body just issues the certificate if the data on criminal records are missing. So by default, based on the presumption of innocence. So this is something similar, as it seems, about this certificates, addiction certificate. Sorry, I could not find this raise your hand function here, so I will just jump in if I may. So from what our colleagues have just discussed, I could say that after our legislation was changed, the situation in our country has become closer to the situation in our presenters' countries. So we do not have narcological registration, but there are certain conditions on which the facilities have to provide information about addictions, previous or current. And again, one of these conditions is a request from the police. But again, this request should be argumented, should be motivated. For instance, if a person is involved in a crime, or also another condition would be an application for the possession of arms, driving license, or some others. And these processes are now registered in different systems. These are not national registries. So every facility has a system of its own, an information system for entering patients' data. But of course, the facilities do not share this data. So they do not share the data with unauthorized bodies or entities. And one more thing that I wanted to mention is that a lot is still to be done to inform the population about the fact that registration or entrance of data in a registry does not entail limitation of the person's rights unless it is required by law in certain very specific cases, as I mentioned before. And as Ms. Federer mentioned before about this 5-year period, yes, I also can say that sometimes people do know that if they do not seek any services from any addiction treatment facilities for 5 years, then upon the expiry of these 5 years, he or she might apply for arms possession or maybe access to some jobs or to a driving license. Yes, this is true. But I would agree with families that we could never have a 100% guarantee that people who have mental health issues, including addictions, would never get access to some jobs or documents that they are not eligible to. Again, I want to thank the speakers for sharing this information. It would be good if we could have a national registry in Moldova as well, not only for addictions, but for mental health in general. and that the personal data would be protected so that our clients would not be afraid that their
Thank you,
personal
Sylvia.
data could be
And
cheated.
actually, what I wanted to say that I know that Pompidou group and our project a bit like we are ready to provide the very practical support. You've heard now about the systems, but I'm absolutely sure that our experts, Victor, Katri, Emily's, like could advise if you will develop some changes. And so the key challenge was the human rights, as I understand. It's not that some regulations are written, but how they are implemented, who have access to this data or that data, how they are used, how people like that. That's all about the cases. So this experience, people could help you if you will develop the changes in your regulatory system even before it will be in place. Maybe we could have another talk, or personally, or somehow to find resources to come to Moldova and to sit and think, okay, that's the patient, and how data is going to the child care system, as it goes, what is the request, how it could damage the life of women who use drugs in the opioid agonist treatment with her parental rights. We know cases from Belarus, and I'm sure that Moldova is not Belarus. But that's like all the possible to safeguard people's personal data in a way to protect their lives, and in same time to implement the legislation and to make the system working, not very complicated and not very heavy and effective. So it's not saying goodbye. It's more about suggestion. If you have very concrete requests on the technical support, I'm sure that colleagues will be ready to step in and to help with their experience, and not only from these countries, but we could find somebody from other countries. Maybe it will be also relevant. Okay, thank you very, very much, Emily, Victor, and Katri, for your help. Thank you, our active participants, for your asking concrete questions. And we will share video as well as the presentations with you. And I'm very, very happy that we having this conversation. That's really important to go to details of this work. Alla, your word.
Спасибо большое. Я добавлю только,
Thank you very much. I would like to add that this issue is very important for us, and our colleagues from EECA and our presenters have helped us a lot to better understand this issue. Thank you.
Thank you. Have a good afternoon.
Bye-bye. Take care.
Bye-bye.
Bye. Take care.
До свидания.